Sorry?
25 years this year.
Of the foundation? Yeah, very good.
Okay, right, we're good to go. So we've got lots of afternoons and mornings for everyone in the room. So the room's nice and busy, which is great. So welcome, Dave. Welcome, Chief. You're both well.
Hiya.
Right, we're live on Facebook as well. So we're now broadcasting. So there we go. Okay, so if you don't know the rules by now, no kicking, no scratching, no pulling hair. No. So what we'd like to do is invite you to ask your questions. So we have Professor Dave Jones, OBE. We have Collette Thain, MBE. Oh, you put your whole email today. So
Me?
we've got,
He's in university. He's behaving himself. He's in the university.
if you look at the chief's title, we've got Collette at PBC Foundation.
Oh, okay.
So somebody's let the chief loose with technology again.
Right. Good afternoon, everybody. I'm going to hand you over to Dave with some questions. I just wanted to start to open and just give you a bit of information. So David is frozen, Caroline's saying. Maybe come out and come back in again, Caroline.
David is good for us.
So I just want to remind everyone, we're coming up to a year since we've been doing this, since lockdown and COVID appeared in this country and around the world. Now, the foundation, we work very hard at giving you the best information available, the very, very best and hot off the press. We're not able to give people medical advice because that's not what we're allowed to do, but we can give you medical information, and that's what our medical advisory board, David, whom is a very senior member of that board, is very happy to do, and they give up their time in order to do this. When it comes to the vaccine, we have Professor James Newberger has written a piece about the vaccine, and it went to Dave for any changes, comments, and it went to 25 other medical advisory members around the world for their comments and correction. And it's reviewed every time there's an update from governments or the World Health Authority, we update that. Now, on the subject of the vaccine, we've been getting some communication, which some of it has been rather unpleasant, about anti-vaccine and what you may think or what you may have read or what you may have seen. We are not here to tell you whether you do or you don't have the vaccine. We're here to provide you with the latest medical updates on the vaccine. Please try not to post anything on our Facebook. We have to take it down. We are not promoting anybody, particularly people who are making a lot of money and don't have medical qualifications. We can't do that. We're here to keep you all safe. And so my recommendation is, if you're not sure, and I don't blame you for not being sure, that is totally fine. Check it out with your own medical team. We'll do everything we can here, but when it comes to vaccines or anti-vaccines, that's not something we can actively engage in. Now, I'm speaking to you as the chief exec now, and I've got a whole body to look after, a corporate body here. And I'm going to, David would like to make a comment from a medical point of view. If you would like to, David, please.
Yes, so thank you, Collette, and I would echo all of those comments. So for those of you who don't know me, I'm obviously a hepatologist managing PBC patients for a long time, and I'm also a clinician working very actively. But also my university title is Professor of Liver Immunology, so my area of expertise is the immune system. So although I don't and haven't worked on vaccines, I am somebody whose area of expertise is the immune system. What I wanted to say is that I think these sessions are incredibly valuable as a forum to talk about PBC and the issues and challenges around PBC. And I think one of the reasons why I'm so keen to do them is that people struggle to get advice and guidance about PBC. And I think, therefore, they're incredibly valuable. My worry is that they have become more and more a forum to talk about vaccines. And I think that loses some of the value of what we're trying to do. These are PBC sessions, and I think we should stick to PBC rather than going into specific things around vaccines. What I would say is my following clinical view, and I've been very clear all the way through around the vaccines. So the first thing to say is that I've been vaccinated. All my family who are eligible have been vaccinated. And I would advise anybody who asks me whether they should have a vaccine to be vaccinated. I think that goes without saying. I would also say, as I've said frequently, that there have been two major advances in the last 200 years that transform public health. One is water being clean, and the other is vaccination. And I was talking to one of the junior doctors this week. When I started as a junior doctor in this hospital, we used to have iron lungs on the ward for victims of polio. And we don't have that anymore, and we don't have that anymore because of vaccination. And I think we can sometimes forget what the world was like before vaccination allowed these things to be preventable. And I think it's very important that we remember that. The other thing is that I think it's just worth saying, and this is very personal to me, is that somebody I know well died of cancer in their 40s last week, leaving 3 children under the age of 9 without a mother. And that was somebody who was unable to get investigations for their cancer because of the COVID crisis. I think that's very important to realize. And so the more COVID goes on, the more we will have stories like that. And she's no longer in a position to worry about whether a vaccine is safe or not. The other is, and I don't want to scare people or create a negative image, but I've managed young people dying of COVID. And it is not a particularly pleasant thing to see or to wish that any person has. I've heard, like everyone else has heard, the scare stories about the clots with the AstraZeneca vaccine. I think it's very important that we trust the people who regulate what we do. So we have all worked very hard with the FDA in America, the EMA, MHRA in the UK about approval for drugs. And I can tell you the process that you go through to get a drug approved, we went through it all for obeticholic acid for PBC patients, is incredibly, incredibly rigorous. And it is the balance of safety and effectiveness is what they look at. And I think we have to trust those organizations to do their job properly. And frankly, I would trust them rather than I would trust Emmanuel Macron for his views on vaccination. I won't give him my views on French politics. He shouldn't give me his views on vaccine safety and efficacy. So I think we have to trust the regulatory bodies that are out there and that have looked in this in detail. When the issue around clots and the AstraZeneca vaccine came out, I did a calculation myself. I'm a scientist. So I looked at the data. And I looked at the frequency with which you would expect to see clots in people randomly in the population. And the number of people vaccinated with the AstraZeneca vaccine over the space of time over which we've been doing it, you would expect those people purely by chance to have 430 thrombosis events, 430. And as far as I'm aware, there have been something like 30 reported in people after the vaccine. So I'm not going to argue the vaccine prevents thrombosis. I think that will be taking the data too far. But I think it's important to say you can pluck a single example of something happening and put 2 and 2 together. And as I said, the last time we did one of these, genuinely, after I got my vaccination, my car wouldn't start the next day. But I'm not blaming the vaccine for that. And finally, I think it's very important to realize is that there are a lot of people out there making a lot of money from the anti-vaccination movement. And be very careful who you listen to and be very careful who you trust. Because there are people, I'm not going to name names, but there are people making a large amount of money by offering alternative cures and alternative approaches. So whenever people tell you about the dangers of vaccines, you will normally find an opportunity for them to provide you with some service that allows you to get around it. And I think a certain degree of skepticism around all of that is important. So I have given my career to giving the best possible advice I can to people. And at the end of the day, people can take that advice or not. And for me, this is as clear-cut as it's possible to be. We are in deep trouble if COVID continues. We'll have more 41-year-olds dying of cancer. We'll have more young people dying of COVID. And we may not have a health service anymore when the money runs out. £200 million a day is what it is costing this country to manage COVID. And to me, the plausible way out of that is vaccination. And I see no risks at all associated with the vaccine. And I think it's therefore as close to blindingly obvious as it's possible to be. And I think it is dangerous and immoral that people profit from scaring people. There's a lot of talk I've heard about freedom of speech and that people can say what they want, and they absolutely can. But also as a society, we accept that you can't go into a crowded cinema and shout fire. There is an acceptable limit to freedom of speech, that you cannot harm the lives of other people through your right to have a freedom of speech. And I think that is very difficult, but I think it's a fact. So I think it's got silly over the last week. I think that a lot of stuff around the AstraZeneca vaccine is pure politics. It's Brexit again and again. And I think politicians in particular should grow up and stop dealing with things they don't understand. So yes, I have spoken in strong terms because I feel very strongly about this. And I don't think that people who scare people who have enough worries about their disease are doing anybody any service. And to do that, to profit from it, is frankly immoral. So I'm not going to take more questions about vaccines. My views aren't going to change. They're very clear cut. And I don't really intend to get into a debate about it with anybody. To me, it's very straightforward indeed. And I think the guidance is there. And I think we have regulatory bodies, certainly in the UK, that are the equal of anywhere in the world if they don't exceed it. And I have spent so much time arguing about the safety and benefits of things. I think we have to trust people to do that. So that's what I wanted to say. And I just think we should all move on from vaccines.
David, thank you very much indeed, and I'm sure you'll there's food for thought for everybody, because I know that people are unsure, and you're very definite what you think and feel, and I think we'll all benefit. So thank you so much, David. I think it's great. And Robert, by the way, you've shaved your beard off. This is good.
We're out of lockdown, so the lockdown beard has gone.
Okay, so what questions we have for the professor then? What is PBC? No, I didn't mean that.
Question number one. Dave, have you any thoughts on
here. Sorry.
Dave, have you any thoughts on the vaccine? No. So no, I think that's actually really, really important. And one of the things that is easy to forget. Now, we as staff of the foundation, Dave, as everything that you do in all your hats that you wear, we're aware of this. But when you're out there in the public, it's often easy to forget that when people come to our organizations and organizations like ours, there's often a fear driver.
Yes. No, I get that completely.
I've got some information and it's only half the picture. What do I need to know? What do I need to know? And part of this is what drives these and what makes them so successful. So I think it's been really good to have that broken down, put it into a logical context, and actually look at the facts as they are. So thank you both.
And I think just to say, particularly James Neuberger and myself, I mean, we have been collectively doing this for 70 plus years. And you will not, you can pass your own comment about me, but you will not find anybody more thoughtful and caring than James Neuberger. You won't. And he thinks about this very, very deeply. And he and I absolutely agree about this. And I think, please just trust us. Please.
Yeah. No, great team. Absolutely great team.
No, absolutely.
Right. Okay. PBC.
Okay. So
that's not to criticise the whippersnappers, the George Meltons of the world.
Like George.
Left school last week and they're now experts,
We had George in last week and he had a young consultant in from King's with him. It was actually very nice, a young lady, Hansi, Dr. Hansi.
Yeah.
Okay.
Brilliant. Okay. So I guess the last point is a point of order. Dave did stress that between Dave and James, that there's about 70 years of experience, and only about 5 of which are James. And
I walked into that. Honestly.
Okay, right. Back to the serious business now. So we've got some good questions. Hopefully we'll get more in the rooms, both here and on Facebook. So the first question is about Hyde's disease, Hydes disease. So apparently it's implications on the feet, but is there any link to PBC, and are there any treatment implications? Help me out. Any treatment implications?
Can I be honest and say I've never heard of Hyde's disease?
Oh wow, okay then.
If you want do you want to just do a little look and see if it goes by another name? But given I've not heard of it, there is no association with PBC that I've ever come across.
Okay, that's good to know. Thank you.
Do somebody have a look and see if it goes by a different name?
It's PN. It's a skin disease, prurigo nodularis.
Okay.
A skin that causes hard, itchy lumps, nodules to form in the skin. The
Okay,
pruritus can be intense, causing people to scratch and bleed, etc., etc. So it's a skin condition.
Yeah. Okay. Right. Fine. Yes. It just goes by a different name. So the answer is no. Although one of the things that we have to distinguish is itch from PBC from itch from skin conditions. And clearly, if you have a skin condition and PBC, then you get two potential causes that can add to each other. So fortunately, that's very uncommon, actually. And so we see a little bit of lichen planus, which is another immune condition. And we see a little bit of what's called lupus, cutaneous lupus, which is not SLE. It's a little bit related to that. And they're about the only things that we see with any frequency. Psoriasis is associated with PBC, but fortunately usually isn't itchy. Eczema is itchy, but is not associated with PBC. In fact, PBC seems to protect against it. So Oliver James did that work with the foundation many years ago, actually, about skin conditions. So the answer is there's no connection, but if you have both, it may potentially make itch worse. Generally speaking, PBC itch treatments and skin disease itch treatments are different. And one of the reasons to work out what the cause of the itch, you could say itch is that actually different treatments are appropriate. So the sort of things that we would use for PBC would not tend to work for skin conditions. So for example, Questran would not work if you have eczema as a cause of itching. And also they will tend to use antihistamines, which we tend to, the dermatologists, which we tend to avoid, largely because they don't work, and partly because they don't work, and partly because they can cause people to sedate, even the non-sedating ones, which makes fatigue worse. The only connection between skin conditions and PBC itch is light therapy. And we've been working with the dermatologists here, Professor Nick Reynolds and his team, looking at light therapy as a treatment for itch. And certainly this is something that works for some people. Many people notice that you get less itch in summer, and there's a medical basis to that, and light therapy can help people. It tends to help people with a big surface area to their body mass. So little people tend to work better than bigger people. I would be a rubbish candidate for it. They need to put another 50p in the meter for the light machine. But it does work, and it's really effective for some people. And it's something that we use in people who are struggling. And so they do that for these skin conditions. The only thing just to say is that one of the things with scratching, so that Hyde's disease, as described, it can arise because people have been scratching. So it's very, very important, if you can, to avoid scratching when you have itch, because that chronic irritation to the skin can itself cause itching. So you are far better to get therapy for it. What I would say about itch is that there is a really exciting set of new therapies emerging for itch. So this has been an area where not much happened for a long time. Then there was the IBAT inhibitor, the GSK trial that people may have been involved with. That is progressing very nicely. That's now going into its final trial. So that's the phase 3 trial that will lead to it being available. So that's a real step forward. The early data are really impressive. They're about to start an extension study. So anybody who's been in the trial of the GSK drug linerixibat, it's called, to date can now go into a study where they can get it open-ended. So if you were in that trial and have lost touch with the trial centre, get in touch with them, either of the 2 studies that's been done. So if you want it, you can now get that drug. We've argued for that. That's a big step forward. And for people who've not been, people who've not been involved, there's the new trial coming along. But actually, after that, there are some completely new forms of drugs, and one of them seems to work on the nerves in the spine that drive itch, which appear to be stimulated by.
Dave's frozen for me.
Yeah, for me, appeared to be stimulated by was what we got. His connection's gone down a bit, I think.
Yeah. I'll give him a second just to come back and see how we go.
Bit of a daft question. Will he be aware that his signal's dropped?
No, I'm back. I'm back. That's right.
Okay.
So stimulated by was what we got. No.
So we got as far as the itch was stimulated by, and then we lost you, Dave. So I remember in the old days, this used to happen to the internet at this time, because America used to sign on.
Well, America sign on. Right,
So
they're ready to stimulated by was what we got, and then
bile acids. Okay, so bile acids, which drive PBC and which are retained, seem to irritate these nerves, and actually being able to block that potentially actually masks the symptom completely. And that trial is about to begin, I think, in about 3 or 4 months' time in the UK. So I think itch is an area where I'm very, very optimistic that we will have a range of therapies. And, you know, we've got existing therapies and many people are well controlled, but we always want to have more options to be able to control it. So that's a really promising area.
That's excellent. Thank you.
Okay.
Can I just say the advocacy of the foundation and the patients has been hugely influential in the companies developing these drugs. So, and I've had that said to me many times, that the sense of need and commitment to it is quite extraordinary. And actually that strongly encourages industry to look at this as a potential area because it matters to people. So everyone deserves a pat on their back about that, because it is, you know, drug companies sometimes get a bad press, but they are the ones who develop drugs. And without their involvement, there are no new drugs. And so I think that message from patients to industry is very powerful indeed.
And of course, that's the PBC app. So anybody out there who haven't got the PBC app, download it. It's free.
Yeah.
Go to your app store and download it, and we'll be asking you questions. And the company and the pharma company.
Exactly, because what they want most of all is information about the extent to which things are a problem. And so what's called real world data is something that is very powerful now, that data on thousands of people that something is a problem is exactly what will encourage industry to invest in areas, because there is a problem that needs solving. So I would echo that completely.
There's a question from Ruth. She says, is recruitment complete on this drug, and where in the UK? So we're coming to you with questionnaires, Ruth. That's through the app, but we'll announce it.
Yes. So the trials that become the trials that open up, you'll be able to hear about them all through the foundation. And, you know, like all trials, they have pros and cons. To go back to what we said before, that there is a very high level of safety assessment in them all. These are all drugs that are being shown to be safe already, that are being applied in different settings. And there is nothing that's going to happen that you won't be able to find out about through the PBC Foundation. One question I've been asked literally twice this week by companies interested in trials of drugs for symptoms is, how far are people prepared to travel to take part in a trial? And what I say to them always is, ask people. They'll tell you whether they want to or not. So suggest not to limit it to, you know, it's there for people. And we always push the companies to have a spread of centres across the country, so that there's somewhere. So there's, you know, across the whole of the United Kingdom, I would say.
Thank you.
Those people north of the border. So just to make sure that you know, we try and make sure there's a centre within an hour and a half to 2 hours of everybody, as much as it's possible.
Excellent.
Brilliant, thank you. Okay, so while we're in the link to PBC section, with somebody, so we've got a father and daughter who both have PBC. They've both acquired anosmia.
Yeah.
Is there a link between this, or is that purely coincidence?
Coincidence.
Patrick, thank you.
Okay. Thank you.
And next question would be aching eye sockets. Could that be related to Sjogren's or PBC or anything else?
Yes. So again, I was having this conversation earlier this week about eye symptoms, and it's very interesting. And this goes back to some work that we did years and years ago. A very bright student working with us looked at eye symptoms, eye pain, eye discomfort. And she looked at whether it was tear production. So for those who aren't familiar, Sjogren's is an immune condition affecting the tear glands and the salivary glands. So you underproduce tears and saliva. So dry, gritty eyes, painful eyes, and then difficulty in swallowing, other symptoms that go with it. And everyone assumes that if you get eye symptoms, it's Sjogren's with PBC. So the two do go together. What she found is that well over half the people who had eye symptoms didn't in fact have Sjogren's. They had normal tear production, but they had eye symptoms. And actually, so we've always regarded that possibly as itch of the eye, that actually PBC patients can of course get Sjogren's, and there are treatments for that, but they can also get itch and irritation in the eyes. And actually one of the things that we do if we're struggling with eye symptoms is to try itch treatments. Again, just going back to the itch, one of the things about it in PBC is it affects odd parts of the body. So it's, you know, back of the head, soles of the feet, sort of strange places that you wouldn't imagine. And we think that eyes are one of them. So some of the symptoms, you know, local irritation people get, we think that could be this localized itch. So it's just sometimes worth trying. So it's sometimes if you've got eye symptoms, worth getting an ophthalmology opinion just so they can formally look to see whether it is Sjogren's or not, because the treatments are a little bit different, but don't discount the possibility that it's itch of the eyes.
Can I just add to this, just for people, you might think to yourself, I don't have dry eyes, my eyes are wet all the time, they run. You have two sets of tears, and one is when you go out in the rain or when you cry, etc. But the other set of tears you're unaware of, every time you blink, you're cleaning your eye with that second set of tears. And it's that set of tears that we seem to have a problem with. And I would say to him, you know, Debbie's questions about aching eye joint, eye sockets, which can be with dryness or fatigue, but I would recommend to everybody to get a good eye drop, you know, an oil-based one. I always show you one up on the screen, but I've not got in the room just now, and I can show you at 4 o'clock. And just pops them in the morning, pops them in at night, and see if that makes a difference, Debbie. But don't think because your eyes are weeping that you've not got dry eyes, because that's not the case.
And just a health warning, anybody, if you do have sudden onset redness of the eye and pain in your eye, then that is one of the features of glaucoma, which is one of the out and out medical emergencies. Okay. It's thankfully very rare. So if you've never had these symptoms and suddenly you get a very painful eye and a red eye, then go to an optician in the first instance, and they're literally. So glaucoma is where you have a failure of the eye fluid to drain properly, and it puts pressure on it, so they can literally measure it. So it's a true medical emergency. It's completely treatable. If you don't treat it, you lose the vision in your eye. So it is just before you put this down. I mean, and glaucoma is not associated with PBC in any way, shape, or form. No. But sometimes people can assume that symptoms are always going to be related to their PBC. So I don't think I've literally ever come across a PBC patient developing glaucoma, but it will happen someday, so just be aware of it. Okay.
Yeah. Wonderful, thank you. Okay, so I've got kind of two questions which I'd like to combine. The first part is swollen, sore, red skin on their finger joints. Is it related to PBC or something else? And then the second part of the question from someone else is that can you explain joint pain? Why is it different in PBC than the average person? What causes joint pain, and is it related to PBC?
Okay, so the first thing to say is that rheumatoid arthritis, so the very destructive form of arthritis that people worry about, is not associated with PBC. Okay, so we don't see that any more than you would by chance. And osteoarthritis, so the other common form of arthritis, is also no more common in PBC than would be by chance. We used to see some, hip and knee osteoarthritis because people got osteoporosis and small fractures and things, but we don't really see that. So that's the first thing to say. So joint pains, particularly of the hand and feet, are quite common, but people always worry that it's rheumatoid and there's going to be joint destruction, which there isn't. So there is an inflammatory, what you call an arthralgia. That's posh doctor for painful joints. First thing they teach you in medical school is how to describe somebody's symptom back to you, but in Latin, and it's like erythema is red skin. And dermatologists have made a career on the basis of saying it's erythema. I've got red skin, doctor, that's erythema. Erythema. So arthralgia is painful joints, okay, and that's quite common. Now that is often associated actually with Sjögren's. So Sjögren's syndrome is dry eyes, dry mouth, and painful joints, and that is the association that you get. But it can be really quite uncomfortable, but it usually is not associated with joint destruction, which is what people are worried with. So where people have got red swollen joints, it's often that. Now you can, just to complicate things, have Sjögren's but only in the joint. So you can have Sjögren's without the eye and the mouth thing. So that's usually what we see. Usually responds quite well to ordinary painkillers, and we usually don't see the sort of complicated forms of arthritis in Sjögren's that people getting Sjögren's without PBC would get. There is another association called dermatomyositis, so which is another immune condition that does associate. It's actually very rare, but it's slightly more common in PBC, and that gives you redness over the knuckles. Usually, you get people to piano their fingers. You can always tell when people have got this discomfort because they hold their fingers in what we call the neutral position. So actually, the place with the position for your fingers where the tendons are relaxed is not that. That's actually pulling back, it's that. So you can always tell if somebody has really got painful joints because they'll tend to hold their hand like that. So that you're not stretching the tendons. Of course, if it's your foot, it will be pain when you walk. So it's always a slightly different. People don't usually talk about joint pains in their foot. They talk about pain or like they're walking on a pebble in their shoe. So it often feels a little bit different. So it's usually to do with the Sjögren's. It usually isn't destructive, and it usually settles down with simple analgesics. Now, where it's problematic, so we have a great service here. So one of my colleagues here is a real expert on Sjögren's and offers a fantastic service. So if we're struggling, he sees people and advises. And of course, Sjögren's, if it's mainly Sjögren's with a little bit of PBC, then obviously Sjögren's has its own treatment options. And we have then a dialogue just to make sure that the treatments that he might want to use are the same, are right for PBC. So this idea that you have a treatment that covers both of them. So if people are struggling, then it's worth seeing a rheumatologist, not an orthopedic surgeon. This is not orthopedic stuff. It's a rheumatologist, and then there can be a dialogue about which treatment options they might look at are the ones that will potentially be advantageous to the PBC as well. So we've actually had people who've done fantastically well from their PBC because of rheumatological treatments they've had. So you can get it, you can have a real bonus from that. So it does require a little bit of thought, but that is pretty uncommon. Most people, it's just arthralgia, not a non-destructive arthritis. Why do people get aches and pains? Generally, they are because of the chemicals the body releases. So we call them cytokines. They are the chemicals the immune system signals that uses to signal to itself. And then they are the chemicals that the immune system produces to damage bacteria and get rid of them. And those chemicals themselves cause irritation. They also cause you to have a temperature. They also cause you to feel tired. And so that's where flu-like illness comes from. It's not the flu virus. It is the body's response to that. And so That's why it's very common to get discomfort, sometimes a little bit of rash, fever, fatigue with inflammatory conditions. It's the body's own chemicals that it uses to signal. And that's why where people have a liver transplant, sometimes if you're getting rejection, it can feel like you've got a flu-y event. It's because it's the same process. So sometimes the symptoms people have don't tell you about where it comes from. Obviously, sore throat or breathing problems, you know, that's flu or a respiratory thing. But the aches, pains, rash, feeling tired and washed out, temperature, that can be from anywhere in the body.
It's the worst thing as well that people, we're talking about joint pain, soreness and stiffness, is not to let them, the joints stiffen up, is to not use them because they're a bit sore. Keep your joints active, and you know, if your feet are a bit sore, don't not walk. You know, because when you move them, you know, you get the fluid, the lubricant back in your joints. Would you agree with that, David?
Yes, absolutely. So you lose mobility in joints very easily. The most notorious one's your shoulder. So if you ever injure your shoulder, make sure you get moving, because it seizes up very quickly and you need lots of, you know, funky movements. If you're struggling with your feet, then there is a profession called podiatry, and people tend to think about them doing nail work in people with, you know, diabetes and things. In fact, what they also do is look at gait and look at the things that affect you walking. And actually, nowadays, there's a whole science called orthotics, which is the, in a sense, production of insoles and things that allow you to compensate for these things. And so they can do a fantastic job at redistributing pressures when you walk, so that you redistribute it away from a painful to a non-painful and get you walking again. So one of those things where they can offer you far more than doctors can. We can control the pain, they can get you walking again, but you need to get back to function. I couldn't agree more.
Absolutely. And don't forget the physios. The physios can give you some marvelous exercises to do as well.
Yes.
Hope to answer your question, Carol. And Caroline. Robert, he's good.
I'm here.
Me muting myself doesn't help.
I'm here.
How hard or soft is your finish at 3?
But it isn't.
Okay, perfect. Thank you. Because we're already in the quick fire round. So
yeah, well, you know, it's going to make no difference.
Okay, so there's another question that says, is dry eyes associated with Sjogren's the same as blepharitis?
No. So blepharitis is a more specific infection, but the term sometimes gets used loosely. So blepharitis is kind of eyelid infection, whereas you can get that, but it's a sort of more broadly based thing. So yes and no.
Okay. All right, perfect. Thank you. So we talked a little about itch there. So we've got somebody whose doctor is trying all sorts of antihistamines for the itch. So the question is, what should they be trying?
So antihistamines. Okay. So antihistamines, we never use them in PBC apart from when we use them in PBC. Okay. So that's a very runic answer. So I wrote the UK guidelines for itch, and we say never use antihistamines, but we do use them. And so sometimes they're the right answer, but they're usually not the right answer. So it's whether it's being used for a particular reason, as I'm going to explain, or whether it's the last thing being tried or the first thing is the key question. So we tend to use them in people who have particularly problems with nighttime itch. So there is a group of people where itch at night is the main problem, and because they're itching at night, they can't sleep. So in those situations, the sedating effect of antihistamines is actually quite useful. So we would use them in people who failed other itch treatments where night itch is the problem, but we would warn them that they may well have an antihistamine hangover the next morning. The reason being that they're cleared through the bile, and that therefore doesn't work as effectively in PBC. So they are sometimes the answer, but they should be the last answer, not the first one. In terms of what you should do for itch, then there is a very well tried and tested sequence of drugs? And the answer is, as to who uses them depends on levels of confidence. So first and foremost, people should be on Urso, because that will set the background for effective management. So Urso at 13 to 15 milligrams per kilogram. And some people will see a significant benefit from for their itch from that, but some won't. So that's your starter for 10. The first line treatment we use is a drug called Questran. It's a easy to use drug in the sense that it's safe, but it's a difficult to use drug in the sense that it's horrible and people don't like taking it. And that's its main limitation. It tastes a bit like wallpaper paste. So it has a texture that it's a drink you mix up, and the texture isn't nice. So we suggest people try chilling it. We suggest people try adding fruit juice to it and try and take it, because it does tell us whether it's a PBC itch or not. And for some people, that's all you need. And for other people, it doesn't work, or they can't tolerate it. After that, it gets a little bit more complicated. And at the moment, we would use a drug called rifampicin, which is an old-fashioned antibiotic. And we're not using it for its antibiotic action. It has an anti-itch effect. So, but that does need you to have blood tests and things monitored. So you have to have a certain confidence in PBC to be happy using it. So GPs would never prescribe it. But most gastroenterologists should. I have to say, this may be about to change, because there is a drug, bezafibrate, which has been trialed as one of the second-line drugs. People aren't responding in terms of their blood tests to Urso, but it does seem to have a beneficial effect for itch. So we are using it increasingly for people with itch. Now, it also has
Okay, so David's frozen for us. What you heard were 4 different syllables, and what your challenge now is to take those 4 syllables and make an entire sentence about the itch. Right? Are you back again?
I think so. I'm on the network, so it should work fine. I mean, it's those pesky Americans.
That's it. Mona, ignore them.
So how much of that did you get? Bezafibrate's a reasonable thing to think about. And most GPs would be happy using it, because they used to use it a lot for cholesterol treatment.
Perfect. All right, brilliant. Thank you very much. So on the subject of, so we talked about itch, we talked about eyes. If somebody, their eyesight is going blurry, is that related to, so they've got PBC, they've got Raynaud's, and they've got scleroderma. Could it be related to any of those? Or are there any other questions they should be asking?
So the vision is going blurry, then they need to get that checked. Now, that's an optician ASAP to have that looked at. Now, the common reasons for vision going blurry are cataracts and things like that. You can also get corneal changes with very dry eyes that will make it blurry. But also there are significant, causes for that. Now, they're rare, like glaucoma. So I think if you get, I mean, the mantra is, if you get any change in your vision, particularly painful eye, particularly vision going blurry, then it's a reason to go to the optician's ASAP, get an eye check. And they will fit you in very quickly with that. And they'll be able to work out what it is. They need to start, they start at the front of the eye and work all their way back. So it's one of those things where the medics haven't much to offer, because they need the specialist equipment. The specialist equipment is with the opticians. And, in truth, the advent of, people like Specsavers has made this very easy and accessible. And, other opticians are available. But, it used to be quite difficult to get opticians appointments, but places like Boots have opticians, Specsavers, Holland 8, Dolan H and all of that. So it does mean it's easy to get appointments very quickly. So if you've got blurry vision or painful eye, get your eyes checked out. It's very likely not to be anything worrying, but it will work out where it is and be able to do it. We have got a bit of a backlog of cataracts because of COVID, of course. And so I know there is a real pressure onto catch up with people, because obviously cataract surgery, where people have got cataracts, is one of the life transforming interventions you can do, but it has been affected by COVID. So another reason for us to get on top of COVID.
Okay, perfect. Thank you. Back into the is it related to PBC section? Granuloma annulare.
No.
Okay. I'm going to move on before you come in with more detail. Having your
gallbladder. I don't have supplementary answers, although I've just done this there.
Having your gallbladder removed. Now, I know that this has come up a huge amount, and when we look at, so in the olden days when we used to get together in a room physically,
yes,
it was often talked about. So can you talk a little about this, please, Dave?
Gallbladders and PBC. Okay. Yeah. So gallbladder disease and PBC are linked, and they are linked because of bile. And so the bile changes you get in PBC, you produce your bile changes, and so it is much more gloopy in PBC than it is normally. And when you get gloopy bile, it sludges up. That sludge can then turn into gallstones. So cholesterol, bile, gallstones are all part of the process in PBC. So historically, we used to see an awful lot of people with gallstone surgery. The very first person I diagnosed when I was a smarty pants, I know you'll find it difficult to believe I was ever a smarty pants junior doctor, but I was. And the very first patient I ever diagnosed with PBC was the first patient I saw as a junior doctor. And she was a lady who'd come in for gallbladder surgery. And so I, being a smarty pants, said she hasn't got gallbladder disease, she's got PBC. So I was a smarty pants. It transpired that her gallbladder was normal, and she did indeed have PBC, an unnecessary gallbladder operation. And I continued to follow her up in the clinic for the next 30 years with her PBC as we all gradually got older and older. So it was certainly something we see. We almost never see it now, and I think that's the Urso effect, actually. The reason is Urso was first invented as a treatment for gallstones to dissolve the gallstones. It's pretty rubbish at that because it takes years. But if you take it for your PBC, then it does seem to prevent gallstones from developing. So we don't see anywhere near the number of problems that we used to. So gallbladder disease causes one of two problems. Either it can cause pain, okay? So you get a gripey, sort of grindy pain over a few hours. That's the classical, eat a fatty meal and get, discomfort with it. And then the other way is and that's where the gallstone sits in the gallbladder and causes irritation. The other effect is if it gets out of the gallbladder into the bile duct, when it can cause a more severe pain, but it also can cause blockade to the bile, and then you can get infection. That again is an emergency, but that's very rare. However, most people with a gallstone have no problems whatsoever. And just having a gallstone does not mean you need to have anything done about it. So a lot of people get an ultrasound scan done for other reasons and are found to have gallstones. That has no reason to do anything about that at all if you haven't got symptoms, okay? The days of preventative gallbladder surgery are thankfully long gone. When do you have gallbladder surgery? I always say to people, if you're getting pain every day, you have an operation. If you get pain once a year, you don't, and somewhere in between, it'll be your decision whether it's a problem. But we tend to try and avoid it if we can. But some people, it becomes very necessary. But as I say, it's less of a problem. Where people come along and do, sometimes where the problem arises is somebody does an ultrasound scan, then looks at your blood tests and go, blood tests are abnormal, gallstones equals gallstone disease. So it's a misdiagnosis in a lot of people. And then the final thing just to say is that there is a thing called gallbladder polyp, and it's something we now appreciate we need to take seriously. So in the old days, it was thought to be part of the irritation with gallbladder disease. It's now recognized as something that can turn bad. So if you have got a polyp in your gallbladder, then we tend to recommend those get screened and they get taken out if they're bigger than about 0.5 centimetre. So that's just one of the things that has changed. But gallbladder disease is overdiagnosed and over considered in PBC, and it's actually pretty uncommon these days. Okay. And I can't believe any of you think I was a smarty pants doctor. I wasn't.
Not saying about.
Okay, perfect.
Whatever.
Thank you. So again, linked to the, is it related to PBC? Biliary stasis?
Yes, exactly. So that's the sludging up. So that's a sludging up. Now, basically, in PBC, you produce more concentrated, more bile acid-rich bile. The bile acids irritate a little bit the liver. That's why you get liver injury with it. So it's about bile acid production. So it just gloops up, and that's where the problem comes along. And Urso does lots of things, but what it mainly does is makes you produce more watery bile. So it washes the bile duct through. So everyone teases me when I'm on the wards at the liver unit at the Freeman, because at the end of a week, all the transplant patients are on Urso. And the answer is because they've all got a connection of the bile duct. And actually, it really helps to have watery bile. It means it doesn't block up. So it's actually quite a good drug for that. It makes you produce just lots of watery bile. You don't notice it because it all goes into your bowel, but it does do that. And so it's quite clever. Obeticholic acid and bezafibrate work in a completely different way. They switch off bile acid production. So actually, obeticholic acid and bezafibrate will in the future stop you ever getting gallstones because you don't produce bile acids with them, but they do work. So that's one of the reasons people often ask us, if I'm taking obeticholic acid, do I need to take Urso? The answer is actually it's probably a good combination because the Urso works in an additive way. So that's why we tend to suggest people still take the Urso.
Okay, brilliant, thank you. Well, so the question is that they had joint bleeds quite frequently on diagnosis, but then on commencement of treatment for PBC, this stopped. They were told it was nothing to do with PBC. Is that correct? Or is it just a strange coincidence?
Okay, well, bleeding and PBC, there are 2 or 3 potential connections, all of which are incredibly rare. So the first one is through what's called vitamin K. So vitamin K is a fat-soluble vitamin. So it's one of the ones you need fat in your diet to take. And if you are short on vitamin K, you can't produce clotting factors, and so you are at risk of bleeding. And for collectors of trivial and obscure facts, it's the process by which warfarin works. So warfarin blocks vitamin K. So people with PBC can sometimes behave like they're on warfarin, okay? Now, everyone worries it's their liver, and it isn't. It's just that vitamin. So one injection of vitamin K, people are fine for the next year because it builds the stocks up. So if somebody was newly diagnosed and particularly if they maybe lost some weight or had loose stools or something, we've talked before about the nutritional aspect. So you can sometimes be a bit light on fat in the diet being absorbed, which can cause vitamin K. So that would be my bet if it's linked. Occasionally, you can have low platelet counts with PBC. So they're the cells in the blood that cause the clot. If you said bleeding in a PBC patient, I would say coincidence. But if it really is associated with starting therapy and it going away, then it's possible. And remember, one of the reasons we don't see the nutritional things with PBC anymore, or anywhere near as frequently, is of course Urso acts as a bile acid to help you absorb fat. So anybody taking Urso won't in fact get problems with absorbing fat because the Urso is acting to help as their natural, accessory for that. So it may well be that somebody, you're a bit short on vitamin K and starting Urso restored fat absorption. The thing about these fat-soluble vitamins, they're A, D, E, and K, is bad hand in Scrabble, but important for nutrition, is that taking tablets won't help, because of course it's not that you're short in the diet, it's that the body's struggling to absorb them. So it is a reason to take Urso and to get the nutritional side looked at and sorted out.
Brilliant, thank you very much. So I've got a question for you, and it feels like a bit of a mastermind question as opposed to anything else. So the question is, what is the name of the group who meet together, different specialists in one room,
Yes.
where consultants can ask other consultants around the country questions regarding any patients who don't normally fall into the normal PBC model.
Yeah, okay, so that's a multidisciplinary team, MDT,
Yep.
is the terminology we use. And it's a really topical question, actually, really, really topical question, because this is something we're actively looking at in the UK now as part of, strangely enough, after Brexit. So one of the things that the government is looking at the moment is there were European networks that supported this, European reference networks. They weren't very good at reaching around within countries. They were good at reaching between countries, but there was a level of networking that didn't happen. And actually, what we're interested in is how do you make that work in practice? So, here I am in Newcastle, the metaphorical consultant in Truro, how would they get guidance with a complicated patient? So at the moment, there are actually two systems for it. So one is a thing called the Operational Delivery Network, or ODN, okay? And that's where decisions about obeticholic acid and fibrates are made. So there is everywhere in the country, there is a specialist center that you can discuss complex PBC with, and that may be what you're referring to, ODN, Operational Delivery Network. And those are about making decisions about second line therapy, okay? And those then filter into the super centers, which are, 3 or 4 across the country, Birmingham, ourselves, Cambridge, London. So there is a network from your GP to your hospital to your regional network to the super networks. The other way, of course, is that since the beginning of time, people know each other and have phoned them up. I get asked all the time by people. It's one of the reasons we go to meetings, and and that's something we're missing with COVID, is go to meetings, people get to know you. I'm, a smarty pants, as we've discussed, but I'm a nice person, and I'm helpful, and so people feel able to email me or give me a ring, and we do that literally all the time about questions. So we've got this person, what do you think? And I get that particularly from all over the country about symptoms, as you might imagine, because of the interest in it. So that's always worked very well. We would like to have something a bit more formalized, largely because if people don't happen to know me, they feel less comfortable to do that. And so we are working on a networking system where we can, where anybody can phone in and get advice. And I have to say, Zoom and all the things we've learned with COVID actually are the answer to that. We never had a way to do it before. But actually, I would think it would be entirely reasonable to have a national drop-in session, 5 o'clock on a Wednesday evening, where any consultant or nurse from anywhere in the country can come online and discuss cases. And I think that's probably the way we'll go. So at the moment, there's in your hospital, it's the multidisciplinary team. Regionally, it's the Operational Delivery Network. We are looking at a national networking system where people can access it. It is there at the moment, but that disadvantages people who don't feel confident, dropping a stranger an email.
Yeah. Okay, perfect. Thank you very much. Next question I have. Medicine regimen. Yeah. So we know, for example, that if you're taking cholestyramine, it's a good idea to keep it away from not only your Urso, but your other meds.
Yes.
So given that background, what do we need to know about taking your Urso, taking your OCA, taking your fibrates? What do we need to know about the medicines working together or not? And should we separate them or not?
So the only hard and fast rule is that Questran will bind bile acids and get rid of them from the body, okay? It binds them in the gut and it all gets passed out. And Urso and OCA are both bile acids, okay? So if you take a sachet of Questran and an OCA tablet at the same time, your toilet is going to be dosed with OCA at great expense to the health service, but you're not, okay? Now, that may not be too much of an issue for the simple reason that OCA does also work on the lining of the bowel. So it doesn't have to go all the way through the gut to work. It can work at the top of the bowel, but I wouldn't want to, take that risk. It's quite an expensive drug. Urso completely binds to Questran. So if you take Urso and Questran at the same time, neither of them will work. It's not harmful, but you just lose the effect of it. So that's the reason why we suggest to people, there are some obscure reasons to do with how gallbladders work. There are some obscure reasons why it's better to take Urso in the evening, although it's not a hard and fast rule. But the main rule is we tend to suggest if people aren't going to take Questran, take 3 sachets spread through the day and then take the Urso last thing at night. You don't need to split the Urso dose. That's a bit of a historic artifact from the old gallbladder days that we were talking about before. And it can be almost impossible to space Questran and Urso if you split them during the day. So all our patients would tend to take Urso once at night. The other drugs, it truthfully doesn't matter. And a lot of it is to do with gastric irritation and things. So the best thing to do is read the leaflets. But people ask us all the time, should I take my Fibrate, before food, with food, just after food? And the answer is, I honestly don't think it makes much difference. And it's whatever is best for you being able to tolerate it. We are going to look with all these drugs, we're going to look at your response in terms of what it does. And if it doesn't work, we'll then look at taking it in a different way. So in a way, rather than worrying up front about the effect, take it the way is easiest for you, and we'll look at whether the effect is enough and take it from there, is the way we tend to do it. But the one hard and fast rule is Questran and bile acids need to be spaced. Bezafibrate is not a bile acid, okay? And so therefore it does not need to be spaced in the same way that Ochre does. Although they have a similar-ish action, the drug type is not the same, and it's specifically the bile acid thing.
Perfect. All right. Thank you. We spoke a few weeks ago with regard to the blood-brain work that
yes.
we were, I say we, you, but the community.
Yes.
Are you any further forward? Is there anything further you can share about that?
So it's grinding its way through the regulatory stuff.
Yeah.
So it is approved. So there are two trials for people with brain fog symptoms, and for a variety of reasons, they are split. One is for people who've had PBC for a while, and the other is for people who are newly diagnosed with PBC. Okay, so, and that's to do with wanting to, in case it doesn't work with people with established PBC, we want to make sure it isn't just that we're giving it too late in the disease. So the one that's for people who've had PBC for a while has gone through its ethics and its MHRA approval, so all the regulatory stuff, and is just in setup in our hospital at the moment. And so I think it'll be 2 to 3 months would be my best guess. Okay. The one that's new onset PBC is one that, and that trial, the first one is going to be in our hospital in the first instance. People can travel from wherever they are if they want to, and then we'll look about other centres down the line.
No, he's gone.
Again.
The MHRA. So about 6 months, I would estimate.
Yeah. Mm-hmm.
Okay. Perfect. Thank you very much. Okay, next question I have. So we've got somebody who a few years ago had a not very good liver scan. They have fatty liver as well as PBC, and then their last liver scan was back to normal and much less fatty liver. Is that a normal thing? Can you comment on that, please?
Yeah, so there's an old saying in our world that what you find at ultrasound depends on what's at both ends of the ultrasound probe. Okay, so the thing about ultrasound is it's quite operator dependent. So people see you do it in real time. I mean, I remember when I was a smarty pants medical student just before being a smarty pants doctor. I remember being handed an ultrasound scan, and this was when it was relatively new technology, so people will have seen ultrasound scans. So I was handed an ultrasound scan, and I was asked by my consultant what I thought it showed, and I said it looks like a high pressure area over Norway, and literally nobody laughed, and I got a terrible telling off, shall we say. the point is ultrasounds are very difficult to interpret, and you can take a picture of it, but it's very difficult to interpret. So in a sense, it's what you see. It's what you see at the time you do it. A CT scan or an MRI has a hard copy that anybody anywhere in the world can access that. There are now very good IT systems that allow us to look at scans at home and things like that. So that can be reinterpreted and reinterpreted, but ultrasound, it's real time. Ditto Fibrous Scan, by the way. So you will sometimes find opinion differences. And at the end of the day, you weren't there. In a sense, you can't check it. And certainly with Fibrous Scan, where there's no hard copy at all, and you will get results that differ, it gets. So when you get an odd result, the first thing we do is repeat it. So we have people who have a Fibrous Scan of 5, which is entirely normal, and then next year it's 18, and they get very worried. And people are worried they've got cirrhosis. Well, the first thing you do is repeat it, and you usually find it's 5 again, and it's just one of those things. So always have a healthy. And honestly, I just summarised the problem with testing with COVID. That if it doesn't sound quite right, repeat the test, and we don't do that. And that's where a lot of the issues with false positives come from. So you do need to just be aware of. I think I might have frozen.
No, I think you're still there.
Okay.
So here.
So could fatty liver disappear in a year? Could.
Oh, you kind of disappearing.
Okay, we'll give him an opportunity to come back in. We're down to your last couple of questions. Are you back there now,
we've still got one here on the screen, Robert, about antihistamines.
Okay, so you can resolve pretty quickly, actually. So it is entirely possible to have fat on one ultrasound scan that's disappeared the next year. It is also possible that it was over-interpretation, when somebody looked at it, and they sometimes get a bit excited. The same applies to cirrhosis on ultrasound. There will be many people on this call who've been told that they have an ultrasound scan that suggests they've got cirrhosis. Ultrasound is a rubbish way of working out if people have got cirrhosis. And usually when we see people like that, it's nothing of the sort. So it wouldn't be unduly worried about that. It's not a really good way. If you have got fat in your liver on ultrasound, it's one of those things. It doesn't mean anything from a PBC perspective. It may mean the blood tests are a bit more difficult to interpret, but it's not a particular issue. But that fails what we call the sniff test. It doesn't sound quite right. And so it's worth repeating it. There is a message there about Fibrous Scan. A lot of people are getting that. Best person to do the Fibrous Scan is the specialist nurse in the clinic, not the doctor. The specialist nurse is and they have many more members. But if you have a Fibrous Scan that doesn't fit in with the sequence, if it was last year and 6 years and it's 5 and then 25, that's not real. So if it doesn't quite feel right, then it's worth asking about getting it repeated.
Okay, perfect. That's helpful. Thank you. You are there-ish, so I'm going to ask my next question.
Sorry, just by one, just to say, if you've got a high Fibrous Scan value, particularly if it wasn't high before, the next investigation is not a liver biopsy, it is to repeat the Fibrous Scan. That's very important, okay? In the early days, people used to get biopsies, and those biopsies would always show exactly what the original Fibrous Scan would be. So if it doesn't feel right, do not leap into biopsy, do another Fibrous Scan.
Okay, that's helpful. Thank you. Somebody's been told that antihistamines are bad for the liver and they shouldn't take them because they've got PBC. Any comments on that?
They're not bad for the liver. They are bad for people with liver disease because of the sedation. So because you can't clear them as effectively, they build up a little bit. And so all antihistamines are sedating to some degree. And even the ones that are, quote, non-sedating ones, they will build up in PBC and you will get more fatigue. So they're not bad for you, they just don't work particularly, and they usually make people.
Okay, perfect. That's helpful. Okay, just check. Yep, you're moving, so I'm going to ask the next question. Is there any particular reason for somebody having a more inflammatory form of PBC?
Oh, that's a fantastic question. So,
for a smarty pants doctor.
for those of you who have taken part in the Cambridge genetic study or UK PBC, or they're all variations of the same thing, you are the people that have contributed to answering that question. Okay, so we are in the process of finishing off a number of studies, myself and George, who you've met, which really get to the heart of all of this. Okay, so the first thing to say is it looks like the genes are the same. So PBC is PBC, and it looks like the antibodies are the same. Okay, so people kind of getting PBC, it appears to be, upstream the same thing in people, and yet it's different in different people. So what it looks like is the body's reaction to what's going on. So in a sense, it's what happens downstream differs in people. Okay. And where we are at the moment, we think what happens is that in some they produce a particular bile acid, which is
I've lost them again.
Overused, you think, in the university?
Oh, probably. The university are really struggling with doing all their online stuff. So we think that people get a particular build-up of a bile acid. They then get a particular irritation in their bile ducts because of that bile acid. And that irritation then makes the body produce these chemicals that drive inflammation. So we think that the inflammatory PBC is a consequence of bad PBC. That's why we don't think that particularly it's overlap with autoimmune hepatitis. We think it's bad PBC. And the new approaches to treatment are going to roll that backwards. So actually, you need to get better treatment for PBC earlier to stop all of that from happening. So we think, for those of you who want a really intellectual explanation, it's a bit like the film Sliding Doors, where I think it's Gwyneth Paltrow. There are two parallel themes in the story. And in one version, she misses a tube train because she breaks her heel, doesn't get the train. And then in the other one, she does get the train, and it's the sliding doors of the train. And it's this unfolding narrative that is completely different, but starts identical. So she's at the top of the stairs. It's called a stochastic model, where it is the sequence of events that starts with a minor difference, but ends up with a very significant one. And just out of interest, we think we know what the bile acid is. We think that bile acid production is switched off completely by obeticholic acid. So therefore, logically, obeticholic acid from early in the disease is probably going to make a big difference. And get this, you can measure that bile acid in the urine of people with PBC that doesn't respond to Urso. So quite extraordinarily, we think it may be detectable in a urine test. And for those of you who took part in that bit of UK PBC, we collected the urine. It was for that reason, because if blood tests are often very difficult to interpret, particularly bile acids, where you have a lot of them. But if you happen to have a urine signal, and we are potentially, and this is not going to happen tomorrow or the week after, you're potentially in a stick test situation, which of course, given that we want people to have ownership of the disease and ownership of their problems, the idea that you could have a stack of sticks at home and be able to detect whether the disease is responding, because you can actually measure the thing that actually causes the problem, potentially is game changing for it all. So actually, although UK PBC ended up doing a lot of work around symptoms and trials and things like that, this is the big UK study. This is actually why we did it. And George and I, we have so we've been pulling thousands of people's worth of data together. And George is not a smarty pants, but he's far cleverer than me. and he's got a brain the size of a planet, and he's busy integrating all of this data. But there are some what are known as marmalade droppers coming out from all of this about why people get it. So we think if anybody wants to understand PBC, have a look at the film Sliding Doors, and it is some event earlier which just goes in one way or the other, and therefore we need to, if you stopped Gwyneth Paltrow going down the stairs in the first place, none of this would have happened. And that's the message, is don't try and work out which train she got, prevent her getting the train in the first place. I've probably tortured that analogy to death, but earlier, better treatment, monitored by the mechanism that actually matters, is the future in PBC.
Perfect. So if I've got that right, when people come to us and say, why did I get PBC? We can say it's Gwyneth Paltrow's fault.
Yeah.
Yes. It's simple to an approximation. And she's guilty of many things, actually. But she does happen to have been in the film, which is the best metaphor for a stochastic disease model like PBC.
Perfect. Very, very quick question. Is there anything that we take? So we've got somebody who's not been on Urso for 3 years. I'm not entirely sure we understand why, but the question is there anything they can do for bloating and constipation? Is it related to their PBC? Yes, probably is the short answer, because of the effects of fat, absorption. So we used to see a lot of this in the pre-Urso days, and those are the ones who then used to get the gallstone disease. So that's slightly into the territory of the old-fashioned bile sludge and gallstones. I think the message is, therefore, to try and take Urso if at all possible. So there's been an awful lot of confusion about Urso over the years, and the message is now really simple, which is Urso universally. Urso universally, that's it. It's as simple as that. So we would want everybody to take Urso if they can. Now, if people can't because of side effects with it, then it's worth running through what the side effects are and trying to mitigate them. So, for example, some people can't take it at night because they get, again, GI disturbance. And so then we suggest they take it during the day or take it with food. So that's where you play around with how you take it. But try and take it if you can. A very small group of people get itch with it, interestingly. So it can cause itch, and that's real. But there are some people who genuinely can't take Urso. And in those situations, the licensed treatment is obeticholic acid. So although everyone thinks obeticholic acid is being used and people haven't responded to Urso enough, as part of its indication, it is people who are intolerant of Urso. And about 1 in 20 people taking Urso in the UK are because they can't take Urso. A $64 million question is, can you take bezafibrate without Urso? And I don't think you can. There is no evidence at all. And I think it specifically has to be ochre. So bezafibrate has pros and cons like ochre has, and they are used, in combinations. But I think if you can't take Urso, it ought to be obeticholic acid you're taking.
It's also worth noting that if particular type of Urso you've got, try another brand or try the suspension. There's a liquid Urso, so don't give up on it right away. Do try everything that's available.
Absolutely, it's very important with all of this. And in our experience, the Folk Urso is the one that is usually best tolerated by people. It is no more expensive. It's an urban myth. That generics are cheaper. They are, but usually they price them to be 1 or 2 pence cheaper. So this idea that you save the health service a lot of money by generics doesn't actually apply for the vast majority of them. And the Folk one, in our experience, is much more likely to be tolerated. Even simple things like they make a 500, and I'm not a supporter of Folk at all. So like all of the things we say, there's no vested interest here. They do produce a 500 milligram tablet, which if you're taking 1500 milligrams is a big deal, because taking 150 milligram tablets, 10 150 milligram tablets is tough. Whereas if you can take 500, 3 500s, that's a lot easier. And they are not, as you might imagine, they're not any bigger than the ordinary ones. So suspension sometimes tastes a bit bitter, but sometimes it works for people. Different formulation, ring the changes. And remember, we go through this all the time. that the pharmacist, if the doctor prescribes Urso deoxycholic acid, then the pharmacist can dispense what they want. If the doctor prescribes Urso Folk, it will be the Folk drug. So it is, ask your doctor to prescribe the particular one. And this is well recognized for some treatments. So for example, people taking tacrolimus after a liver transplant, you have to specify which one it is. For people taking for blood pressure, like I do, it's well recognized that people get adapted to the one they take, and you mustn't change it. So GPs are used to this, and I think for most people it's not an issue, but for some people, you know, and if you're having problems, it's far better to try a slightly different version than it is to not to be treated properly.
Yeah, that's fair. Yeah.
Okay, perfect. All right. 2 more questions, please, Dave, if I can.
Okay.
Number 1, patient's been recommended SAMI for fatigue. Any thoughts?
Yes. So yeah, indeed. So S-adenosylmethionine is a really interesting drug. It is somewhere in between a vitamin and a drug, and a food supplement. You can actually get it via the interweb from sports shops in America. It's not
He's gone.
thing where it's a food supplement. Basically, it appears to be a vitamin that is depleted in PBC, absolutely. And there is some evidence from a trial, it's actually a pretty good trial from 30 years ago, that it treats fatigue in PBC. And I am working and have been working for several years to persuade the company that it's one of these drugs that's been passed around lots of different companies, but it's currently owned by Abbott Pharmaceuticals, and I am working really hard on them to do a trial because it's completely safe, it's perfectly well tolerated, it's a vitamin, and there is a trial from 1990 that shows it works. It's widely used in Russia and the eastern states, and there is plenty of information from patients there that it works for fatigue, but at the moment we can't get it to people. So but as often happens with industry, we were getting there with them, and then they've changed personnel. So I've now got to start again persuading the person that it's a good idea. But so if anybody has a relative works for Abbott Pharmaceutical, they're bonkers not to, because it's safe, well tolerated, with the trial evidence, and it meets my criteria, which is a treatment you give to everybody on day 1 with PBC. So because it's a supplement. So it's the perfect treatment that we would like to evaluate. We've written them I wrote them a trial protocol, and I've written the trial for them just to try and persuade them. But that's big industry. It's why it's interesting. We work with small companies and work with big companies, and the small companies are really easy to work with because you can just pick up the phone and speak to the chief exec, and I'm reasonably good at selling these ideas to people. With these big companies, you've got 14 layers of management that change all the time.
Yeah.
Okay. Obviously, if we can help in any way, David.
So what I would suggest is if anybody does get it, or goes to the interweb and buys it from Gym Supplements R Us in California, do feedback to the foundation. If anybody, it's perfectly safe. Okay, you're not running any harm whatsoever from taking it. I would strongly suggest that you get the app. You record your fatigue, and as you take it, record your fatigue over a length of time afterwards, and let us know the answer, because some pilot data like that, real world data, would, I think, persuade.
Yeah, excellent, wouldn't it? Yeah, yeah.
I'm convinced it will work. I really am, based on the biology of it. It's turned into a thing called glutathione, and it's one of the chemicals that is absent from a lot of PBC patients. It's a normal vitamin.
Okay, perfect. Thank you. Last question then. I'm asking you.
It's gone. So there's a real evidence for SAMI, but if you do take it, record your data.
Right, we need to be very quick now, Robert.
Yeah, absolutely. So last question. And sleep.
Sorry?
Any issues with PBC and sleep?
I lost you. I only heard the word sleep.
So the question is, are there any kind of clinical reasons why PBC could affect sleep?
Yes. It's part and parcel of the fatigue complex. So it's very well worked out. Sleep there are several types of sleep abnormality. They're very common in PBC. There's often daytime sleepiness as part of it, but you can also have difficulties getting to sleep, and then what's called, latency issues. So, difficulty going back to sleep if you wake up. So the commonest cause is itch at night, and that's the first no-brainer to look at. So we always look at itch at night as a first thing to do, and if that's easy, you treat it. Then the next commonest thing is taking stimulants, so tea and coffee. It's a very British thing to not be able to sleep and go and have a cup of tea, which is the worst thing you could possibly do, because that makes the getting to sleep more difficult. But once you've done all of those, it is associated with poor sleep, and it's to do with brain function. And watch this space, because there are a couple of trials of drugs addressing sleep in PBC as part of the fatigue complex coming your way very shortly. So one of the areas we're working with industry on is this combination between concentration, sleep disturbance, and fatigue, real association. So there are some simple things that we do with people, but we are actively looking at drug treatments for it.
Okay.
Perfect, thank you.
Right, I'm going to thank you very much, Dr. Smarty Pants. I think Robert would like to stay on the line, if you could just stay there a moment. Yeah. And Robert, thank you very, very much as well. Long session, David, that's brilliant. Thank you. Everybody, I hope we've answered all your questions. If not, bring some more in for next week. I'd also say to you, look, we are, the money is going down, and if you're enjoying these sessions, you get something, if you can manage, please go to our website and donate. We're heavily dependent, and we're getting very, very few donations in. So I would ask you, please, to think of us, because if we don't, then we're not going to be able to continue. So thank you, everybody. I'll stay put and I won't touch the keyboard. I'll leave everything in Robert's control, and I'll be back at 4 o'clock, everybody, and Phelan Mitchell, see you soon. Thank you. Thanks, David.
Thanks, Dave. Last thing for me to say is thank you all. On Tuesday at 2 p.m. UK time, our session is going to be actually covering sleep and sleep hygiene from a non-clinical point of view. So again, you might get some useful tips there. So other than that, thank you for joining us today.
And although sliding doors is a fantastic metaphor for PBC, almost any other Gwyneth film will do for helping you get to sleep, from my experience. So that Gwyneth has contributed in more than one way.
I missed that. What helps you get to sleep?
Just Gwyneth Paltrow films.